Welcome. Well, my name is Aisha Akhtar. So my name is Aisha Akhtar. I'm the VP of Health Equity at the Epilepsy Foundation of Greater Chicago. So thank you for being here today for our third roundtable in the summer series. So we are really excited to do this series. We're definitely going to do more. If you haven't seen the first two, you're able to grab them on YouTube, and this is actually also being live streamed on YouTube as we speak. So super exciting. I wanted to just make sure we thank all of our series supporters and in-kind donors. You're going to see next door, which you might have already seen, some of these items. The canned drinks we will have available for you on your way out, so you can grab one of those as a little party favor. Do with it whatever you want, but that's what we're doing. So today we are diving into the topic of women's health as part of health equity. We know either from lived experience or from research that women often have a difficulty in obtaining the best health care, and whether it's a lack of access, a lack of knowledge. Today, we want to talk about how we can address these issues. And so I think it's really important that we have all of the aspects of the life cycle of women, including postpartum depression, which I'm so excited to include as well, because I don't think it's just discussed enough. So with that, we're going to hear from our four experts, and Dr. Becky O'Dwyer will be our moderator for today. But before I turn it over to her, I wanted to invite our interim president and CEO, Alicia Vega, to come on up and welcome you as well.
Thank you, Aisha, and thank you, everybody, for being here today. I just want to take a few minutes and share that nearly 140,000 people in the Chicagoland area are living with epilepsy. And at the Epilepsy Foundation of Greater Chicago, our goal is to ensure that every single person living with epilepsy knows that we exist and that we are here to be on the journey with them throughout their lifetime. We provide an array of services completely free of charge. We don't ask you about insurance. We don't ask you about your income. We only ask you about what you need. So we provide care coordination services. So we know it's very difficult to navigate the healthcare system in this country. So we have staff that will help navigate the system to make sure that you get to the right type of care that you need. We know that epilepsy has an impact on your mental health. We have a team of clinicians who are available to provide services to you as well. We know that there is a lot of stigma and discrimination for those with epilepsy, and we have social and community programs so that you can be with others who are having the same experience and be able to network and connect and learn from each other and feel safe in an environment where you're completely welcome. If there's anything you're going to leave, you're going to learn about a whole bunch of stuff today, but I want to make sure that you know epilepsychicago.org. epilepsychicago.org. If you are a person living with epilepsy, or you're a family member of someone living with epilepsy, epilepsychicago.org. Go there and you will find everything you need to get connected to us. If you are a service provider, please be sure to share epilepsychicago.org with anyone that you know that is experiencing living with epilepsy, especially at initial diagnosis. We are here throughout the entire journey, which we know is a lifelong journey. So we appreciate all of you being here, and I'll go ahead and hand the floor back to Aisha.
Thank you. Just a little bit of housekeeping before I kick it off to our amazing panel. So the restrooms are just to the, if you come out and you head that way, that's where they are. All of you have received drink crystals. So that's just a fun little interactive thing. We're doing voting, so make sure you get an opportunity to vote for your favorite social determinant of health. And then also on the board, we're collecting ideas, crowdsourcing for the next round of roundtables. And then also, if anyone parked and the lot that was suggested, validation is there as well. And if you need anything, just holler. Ask us. So I hope everyone has a great time, and now I'm going to kick it off to Dr. O'Dwyer.
Yeah, Okay, thank you so much. I just want to take this opportunity to thank Aisha and to thank the Epilepsy Foundation for organizing this. We're very excited, all 5 of us, to talk about this subject that's dear to all of our hearts. So let's kick it off. Our first speaker is Irina Belinsky. She's a colleague at Northwestern University. You can see her bio there. I'm not going to read it out. There's too much, and I'll start stumbling on my words, but she is going to talk to us about resources and current research in epilepsy and pregnancy. She's primarily going to talk about the Epilepsy and Pregnancy Consortium. So thank you. Welcome.
All righty. So I will watch over there, so please don't feel ignored, but I have to see my screen. So I'm Irina Belinsky. I'm a research nurse. I've been at Northwestern for 14 years now. And epilepsy is just a wonderful area to be involved in because I feel we can help so many people. So what I would like to talk about is from bench to bedside, research results for public consumption, which means what does research look like nowadays? So first off, I'd like to start with a disclaimer that for purposes of this presentation, the term women will include birthing parents, gender diverse people, as well as adolescent girls. So historically, women with epilepsy have faced many challenges and misinformation as far as it pertains to reproductive health. Even as scary as 100 years ago where there was forced sterilization, which fortunately we are done with, we have advanced to knowing that pregnancy is safe, but many times women would hear, you can be pregnant, but you cannot breastfeed, and misinformation like that. And then the only way, since research in pregnancy is not really feasible, that we've been able to collect information on pregnancy outcomes in epilepsy is through registries. So the big ones that we have are the North American AD registry, EURAP is in Europe, there's the UK and Ireland registry, there's an Asian registry, and an Australian registry, which is a wonderful way to collect information. But the drawback is that it's all self-reported, which many times people with negative outcomes tend to report more likely than people who have positive outcomes. And also it tends to concentrate on physical malformations. So the big part that we think about is cognitive outcomes, which is not really well captured, especially since some of them go out only 6 months to a couple of years. So in '99, Dr. Paige Pennell and Dr. Kimford Metter, who are big names in women's health and epilepsy, got together and said, we need to collect some information prospectively, and the only way to do that is through observational research, which means we're just going to be following people doing whatever they do, but we will collect information in a concerted way so we can actually make some inferences from that. So from '99 to 2009 was the NEED study, which looked at monotherapies with carbamazepine, lamotrigine, phenytoin, and valproate. And the main outcome they were looking at was the child's IQ at age 6. And this study is the one where we learned that valproate can cost a kiddo up to 10 IQ points if mom takes it during pregnancy. So it was a very important study. And then as the study was wrapping up, other medications came on the market. So they said, well, we need more information. So now we have MONEED. It stood for maternal outcomes and neurodevelopmental effects of anti-epileptic drugs. And we looked at monotherapy as well as polytherapy, and the big part was that levetiracetam was included. So we were looking at mom, how is mom doing throughout pregnancy? We collected her OB files. We looked at delivery outcomes, and an interesting part that was made very obvious is that if a mom with epilepsy delivered at an academic center, most of the time she had a regular vaginal delivery. But somehow, being at an outside hospital, at a community hospital, it seemed to be an automatic C-section, which is not something that is really necessary. So we have official data showing that some people, especially in smaller hospitals, just feel uncomfortable delivering a mom with epilepsy. We also looked at mom's anti-seizure medication levels. So we would check their levels for the study, but we would also collect whatever was done as standard of care, so we could see how quickly some levels would drop. A cool thing that wasn't done before is that we would collect the breastfed infants, we would do a heel stick and we would check the level of the ASMs in their blood, which was wonderful because we could confirm that most ASMs do not transfer to the baby in significant quantities, which is very reassuring that since baby was already exposed for 9 months, we definitely now have proof that breastfeeding on most ASMs is safe. And then we also followed the child as the main outcome. We were looking at their health as well as their cognitive development until the age of 6. And then so today's challenge is, how do patients find out about all this cool stuff that we found out? How do clinicians treat and counsel patients regarding contraception, pregnancy, and postpartum with most up-to-date information? And so that is a question that the 1-8 Philanthropic Foundation brought to Dr. Pinnell for her study and said, you've done all this wonderful research. How do people get to it? And she didn't really have a good answer. So in 2022, the Epilepsy and Pregnancy Medical Consortium was founded. So it's Dr. Pinnell, who was the PI on Monid, Dr. Gerard, who's my PI here at Northwestern, Dr. Pack out of NYU, who is part of the AAN guidelines on women's health and epilepsy, Dr. McElrath, who is an MFM obstetrician, who was also part of the Monid study, and then Dr. Carolyn Dutton at Beth Israel, who is an obstetrician. And so so we got together, and Dr. Gerard said, we need somebody to organize all these doctors. That's where I come in. And so I've been wrangling them. We had a couple of meetings. I have a equivalent at the 1-8 Foundation, and the two of us are kind of moving the process along. Marketing firm was involved, and we said, okay, how do we take these wonderful findings and make them accessible to everybody? And so in 2023, epilepsypregnancy.com went live, which was wonderful because everybody now had access to free information. And another wonderful thing was that we collaborated with the Epilepsy Foundation, and they updated all of their women's health content to kind of match ours. We've done patient advertising, so they were online campaigns, as well as, I think still right now, if you Google it, there's like the sponsored Google ad that will show up when you search for epilepsy and pregnancy or contraception and epilepsy. And then I have been traveling to AEN, AES, all the neurology, as well as OB conferences, trying to tell doctors about this. So what are the topics that are covered on the website? The first one is simply living with epilepsy. From the first time when you have a seizure, how do you get a correct diagnosis? Because from then, everything else trickles down. Then how do you choose a care team? Do you even get a choice? Are you located somewhere very remotely and this is the best you're going to get? Is it possible to get a consult maybe? Then what are good anti-seizure medication choices? You know, if you get diagnosed when you're 20, people might think about, you know, reproducing later down the road, but like when you're 12, most people don't think about what to start you on. Then there's also talk about supplementation, folic acid, how much, how soon, and then birth control choices, because that's an important part, because some birth control can influence your ASM, some ASM can influence your birth control, and so what do we give you that is most effective and does not influence your medication? The second area is pregnancy planning, which is simply choosing an OB, somebody who knows what it means to have epilepsy and what comes with that. Many women with epilepsy have fertility concerns. Does it mean I'll have a harder time getting pregnant or not? So we address that. The other part, which definitely in the last few years, is heredity of epilepsy. What's the likelihood of my child having epilepsy? And the availability of genetic testing, that it's not, you know, an automatic, you're going to pass this on, or an automatic, oh, you're going to be fine, there's just a small chance. What is the actual chance, and then how genetic testing plays into that. We're also talking about ASM safety in pregnancy, and then also switching ASMs prior to pregnancy. Let's say you are on valproate, because that's the only thing that worked for you. How do you move over safely to something that will hopefully be safer during pregnancy? And that process takes time. So it's not, don't go to your doctor and say, I want to start trying to get pregnant. It's like, in a year, I might like to consider having a family, so what do we do to get me there? The third section is pregnancy and delivery, which talks about pregnancy management. What are all the visits you should have, both with your neurologist as well as your OB? How often should we check your seizure medication? Because I met with an OB out of Australia at the ACOG conference, and he said, every month? Like every month for everybody, you make them come in? Like, yes, that's a good idea to check their levels frequently. Because if we check your levels, we can adjust the medication. I mean, your doctor can adjust the medication to ensure that you don't have breakthrough seizures. Because seizures, most of them should be mostly safe, but if you have a generalized tonic-clonic seizure, it might come with some repercussions. And then also what to do with unplanned pregnancy, because more than half the pregnancies in our population are unplanned. So what do we do if you do end up getting pregnant without having that year to prepare? And then labor and delivery. What's a good safety plan? What's a good thing to talk to your doctor about? You know, should you have some Ativan bedside and things like that? So it's just important to know, and also that you don't need to have a C-section, unless it's medically indicated otherwise, of course. And then for the postpartum period, we talk about ASM tapering, because you go up so much throughout pregnancy. How do you make sure you don't go toxic as soon as that baby is delivered, and then you're getting all wobbly and dizzy with a 2-day-old infant? Not a good combo. We talk about breastfeeding and what it requires, because this baby wants to eat a lot, but mom also needs sleep. So how do you balance that? Postpartum care, both for mental health as well as physical health, like how often should you go see your neurologist? When should you check in with somebody and ask for help? Postpartum safety and support, you know, how to handle a baby, not to give them a bath by yourself, walk them around in a stroller and things like that, because you don't want to have a seizure during that very sensitive time. And then, of course, birth control options. How do we make sure we don't see you again in 3 months? So as far as patient tools go, we have both patient and physician videos. They're very short, they're very simple and easy to understand, because we don't want to overwhelm you with a long lecture. So the physicians talk about patient questions that have been posed, and the patients just share their experience of what it's like to be a woman with epilepsy and what challenges they have encountered. We have various handouts that talk about just the life cycle as a woman, kind of all 4 of those sections that we talked about, what are questions patients might have had, and then what are the answers to that. We have a whole section on Epilepsy Foundation resources, because the website is wonderful and has a lot that patients can use, so we link back to that. There's a section on podcasts and webinars and other helpful websites. Of course, we want to gather more information through registries, so we direct the patients back to, you know, give us the information that we need. There's Kelly Mom, which talks a lot about breastfeeding, mother to baby, checking medication as it, you know, as it goes through breast milk, and then WIC, which is just a wonderful program that can support moms, whether they're breastfeeding or not, just with nutrition counseling. So this is the website. This is what the first thing that you see when you get there. Epilepsypregnancy.com. Don't let the title fool you. It does involve contraception as well, so if you don't want to get pregnant. And the wonderful part that we have now is, hold on, the whole thing is available in Spanish. So you can translate the website can be translated, so everything that you might need for your patient is available, as well as all the handouts. So you have stuff you can give people they can actually use. And then everything is geared towards the patient, but up top there's this button for clinicians where it will ask you, you know, are you an OB, are you a neurologist? It's not there to get you to sign up for anything or take your money. It's just kind of checking in that people don't go down a rabbit hole with too high-level information. So it's there and it's available, because in there we just have higher-level tools. Like this wonderful tool that I've been getting wonderful feedback on, these 2, is the first one is the epilepsy and pregnancy appointment calendar. You can put in your due date, and then from there you can calculate all of your dates, and it says, when do I need to check my levels? When do I need a level 2 ultrasound? When do I need to have my delivery and tapering plan? And then also after delivery, how do I go back down in a safe manner? So it's very personalizable. And the other part for the doctors is that there is a Word version as well, and you can copy and paste into your Epic or otherwise, whatever your medical record system is. And so you can personalize it there. We have also the tapering schedule, which this is the front page that you see on the right, and it just has an example for lamotrigine and levetiracetam, because they're the most common ones. And then the second page is blank, so you can, again, write it in exactly what it is for your patient. And for the patient handouts, I know that all of us have Epic, but all of us have slightly different Epics. But there is a way that you can attach handouts, or at the discharge instructions, you can provide them to your patients. So you can see, you can make your own library, you can add these handouts that are in PDF form. And also, people have just been writing, as part of the discharge, it just says visit epilepsypregnancy.com for more information. So it's a wonderful way to empower your patient to just peruse whatever is of interest to them. And then there's a whole list of scientific articles that back up all this information that we've put on the website. So what is next, at least for me and my efforts here in Chicago, is that I will be at both Epilepsy Foundation Fall Walks, which is on the 21st in Wheaton and on the 28th at Montrose Harbor. And I'm just there to tell the patients about another way that they can find out more about how they can both help themselves and talk to their doctor better. We are in the process of having free continuing medical education videos, which is wonderful for doctors. You don't have to pay for it. You just get to watch and learn about contraception, pregnancy, and postpartum. They should hopefully go live in the next 2 months, but all the red tape takes a while. Also, the new AAN guidelines came out recently. So we're meeting with the doctors in October to update everything, make sure everything jives. And also, Dr. Gerard is part of the UpToDate team, so aligning UpToDate to be available in Epic, which can then make sure that you can pull in the articles and all the information that you need. And another thing that I'm working on is more pediatric outreach. Like I said, as soon as people see the word pregnancy, they walk past my booth, and I'm like, hold on, there's the part where you don't want pregnancy, and that's where it pertains to pediatric patients. So I should be going to the Children's Neurology Society meeting, and just talking to Lurie Children's. And then we also have an effort where we're reaching out to other large academic centers because we want this information, since this is, the source of the truth. We want us, whether you go to Mayo or Cleveland Clinic, we want it all to be harmonized because it's all the same. So we're working on that. That one is a little tougher nut to crack, but because nobody believes us, we just want to provide good free information. So that is kind of all I have now. And outside I have folders that have some of the handouts inside, as well as my card. But big disclaimer, I do not provide medical advice. If you have any ideas, if you have any requests or what you think might be good and helpful on the website, I'm all there for that. But if you ask me, this is my case and this is my diagnosis, I am not a physician. I cannot provide you with anything there. But that's it. That's all I had. Thank you so much for your time.
Oops. Oh, uh-oh. Okay,
I'll get it. Sorry.
It's okay. Okay, so sorry about that, folks. Okay. Great. So thank you so much. That was very informative. So now we have 2 websites to remember, epilepsypregnancy.com as well when we leave today. And next, I'm going to invite my colleague, Dr. Alexandra Moyes, who works out at the VA. And she's going to talk to us actually, which is a nice little segue, about birth control and anti-seizure medication. So thank you very much. We'll get it up and going. I'll pass it along.
All right. Hello, everyone. My name's Alex Moyes. I'm one of the epileptologists at the Jesse Brown VA. And today I'll talk to you guys a little bit about women with epilepsy and contraception. Disclaimer, I am by no means an expert on all the different contraceptive options, and I always defer to OBGYNs and recommend that patients discuss with their OBGYNs as well. But the majority of the talk today will be looking at anti-seizure medications and contraception. So a little bit of background. There's roughly 1.5 million people with gestational capacity that also have epilepsy in the US and more than 15 million globally. And there's been studies looking at these patient population and looking at things such as pregnancy, unintended pregnancy, contraceptive use, and all sort of the interplay with everything. And there's been some notable statistics that have come from these. For example, 79% of women with epilepsy have had one unintended pregnancy. 65% of pregnancies in women with epilepsy were unplanned. 30% of women with epilepsy were found to not be using a contraceptive method that was considered highly effective. 47% of women with epilepsy were using some sort of systemic hormonal form of birth control. And this is important because there's a lot of interactions with this class of contraceptive in particular that we'll sort of discuss in the subsequent slides. Of the women with epilepsy, 25% that were being followed by a neurologist weren't even counseled on contraceptive use. Additionally, studies have shown that contraceptive failure rates vary by the type used and, of course, the type of anti-seizure medication that the patient was on. They found that oral forms of hormonal contraception had greater failure rates than non-oral forms, and that 25% of unintended pregnancies in women with epilepsy were due to oral contraceptive failure. And then the intrauterine device had the lowest failure rate. So why is this important? It's important because we know that unintended pregnancies are associated with increased rates of congenital anomalies, spontaneous abortion, premature delivery, low birth weight, infant mortality. And we know that some forms of birth control become less effective when they interact with certain anti-seizure medications, thus then leading to these unintended pregnancies. And not necessarily related to pregnancy, but sort of on the flip side of this last point, we also know that some anti-seizure medications become less effective due to certain birth control medications, thus increasing the risk of having a breakthrough seizure, which is not beneficial to either pregnant or non-pregnant women. So we'll start talking a little bit about hormonal birth control first. So hormonal birth control includes the oral contraceptive pills, the progesterone only pill, also known as the mini pill, the Nexplanon implant that goes in the arm, the vaginal ring, the estrogen patch, and the Depo-Provera, or also known as the progesterone injection. There's a little asterisk here. We'll talk about that a little bit more in a subsequent slide as well. So we know that the estrogen and progesterone hormones can interact with some anti-seizure medications via enzyme induction. So what this basically means is that anti-seizure medications will upregulate some of the enzymes and then accelerate the body's metabolism of these hormones that are in the hormonal birth control. So they become subtherapeutic in the patient's body and then less likely to be effective in preventing pregnancy. So which medications do this? So this list here is a list of the anti-seizure medications that make hormonal birth control methods less effective due to interactions, due to that increased metabolism, and then can lead to the risk of unintended pregnancy. So carbamazepine, oxcarbazepine, eslicarbazepine, topiramate, cenobamate, also known as Xcopri, which is sort of the hot new drug these days, rufinamide, phenobarbital, clobazam, perampanel, phenytoin, felbamate, and lamotrigine. And then, lamotrigine is highlighted here because there's sort of this two-way effect where hormonal birth control affects lamotrigine and the lamotrigine affects hormonal birth control. So we'll touch on that a little bit more because it's a very important concept. Additionally, some studies have shown that emergency contraception, so Plan B or the morning after pill, can also be affected by these medications, making it possibly less effective. So really, bottom line, if a patient is on any of these anti-seizure medications and on hormonal birth control, we recommend that they use an extra form of protection, such as a barrier method, such as condoms, just to reduce that risk of any unintended pregnancy. The good thing is that we do have a good list of very good medications that do not affect hormonal birth control. So things like levetiracetam, brivaracetam, lacosamide, ectosexamide, gabapentin, valproic acid, zonisamide, the benzodiazepines, pregabalin, tiagabine, and vigabatrin. So circling back to the Depo-Provera, the progesterone injection, so for the sort of general population, it's recommended that it gets redosed every 3 months. There's been some data suggesting that more frequent dosing than the standard might be helpful in women who are on any of these anti-seizure medications that we know can interact. And they recommend increasing the frequency to anywhere from 8 to 10 weeks. I do think most of us would probably still be more conservative and still recommend an extra method of contraception, such as a barrier method, again, just to reduce that risk of any unintended pregnancy. So we know that some anti-seizure medications that we just discussed make hormonal birth control less effective. There are certain medications where the hormonal birth control will cause increased metabolism of the anti-seizure medication, thus possibly increasing the risk of seizure. So again, lamotrigine is popping up here, and we'll talk about this one in depth on the next slide, but it can also happen with valproate, topiramate, and oxcarbazepine. And lamotrigine, again, is important to talk about because it's one of those medications where it's very good for multiple seizure types, and then it's also very safe in pregnancy. So a lot of women will likely end up being put on that medication if it's deemed to be a good one for them, because we do know that it is safe in pregnancy. So what we know is that hormone-containing birth control will cause decreased blood levels of lamotrigine. And studies have shown that lamotrigine levels can decrease by 50% within 1 week of concurrent use of lamotrigine with a hormonal birth control. So if you have a patient that's on lamotrigine and they decide to start a hormonal birth control method, it's important to monitor the blood levels closely, because the lamotrigine levels will end up being metabolized quicker, and you'll basically need to increase the dose of lamotrigine. Now, if someone is on a hormonal birth control and on lamotrigine, they're doing well at a steady state, you have a good dose going, but then they decide to stop their hormonal birth control, again, it becomes very important to monitor those blood levels closely, because now that increased metabolism, because of the hormone, is no longer there. Lamotrigine levels will increase, and you'll need to make an appropriate decrease in the lamotrigine dose. And this last point is also important on women who are on oral contraceptive pills, where they're doing the 3 weeks on and then the 1 week placebo, if that's occurring, because that change going from the 3 weeks of having the hormone to the 1 week of the placebo is enough to cause changes in the blood levels. So, ideally, if possible, we would advise women not to be on the oral contraceptive pill if they're on lamotrigine, just because there's a lot of fluctuations that can happen. Or even if they're able to just, skip the placebo week and just take the hormone continuously, which I know is an option. So what are some non-hormonal birth control options? There's barrier methods such as condoms, diaphragms, cervical caps, and then there's the intrauterine devices. There's the copper IUD, which, as the name suggests, has copper. And then there's the progestin IUD, which I think is sort of the more widely used type of IUD. And yes, progestin is a hormone. However, in this case, there's no systemic hormonal effect. We don't worry about the progestin in these IUDs interacting with the anti-seizure medication, so we sort of lump them into the non-hormonal category. So the good thing about these is that these do not affect anti-seizure medications, and anti-seizure medications do not affect the efficacy of these. So from an epileptologist standpoint, the gold standard really is the intrauterine device. Its efficacy is not affected, again, like just mentioned, by anti-seizure medications. It itself does not affect how anti-seizure medications work. The failure rate is less than 1% per year, and it's just easy. Patients don't have to worry about remembering to take a pill or remembering to get an injection every so often. It's overall, I think, just a lot more easy to use, and it's, if they decide that they want to go ahead and get pregnant, they can go in, have it removed. It's relatively easily reversible. Now, that's, obviously an epileptologist viewpoint, and every patient is different. Some patients might not be able to have it for whatever reason. So, take this with a grain of salt. Every patient is different, and it's always going to be a conversation with each individual patient, each individual case, and of course getting their OBGYN involved as well as, they would be the ones monitoring and prescribing these contraceptive methods. So in summary, it's important to discuss birth control options early and often, especially, with young women. I often recommend in collaboration with the OBGYN, it's important to discuss all the options available, possible interactions with anti-seizure medications, and thoughts too about, like, down the line, will they want to become pregnant? How will they need to be possibly changed to any different medications, and what are the interactions that could happen? And again, just to sort of end, our gold standard is still the intrauterine device. It's just a good method where we don't have to worry about interactions with anti-seizure medications or vice versa. So thank you guys for listening. Wanted to thank Dr. Elizabeth Gerard and Alexa King as well, who've been my mentors in all things related, women with epilepsy related.
Great, thank you so much, Dr. Moyes. If we'll forward the slides on. Our next speaker is Dr. Anna Serafini, and she is coming from University of Illinois here in Chicago. She's going to talk to us about epilepsy and pregnancy.
Thank you so much. This is working, yes. I've been at UIC for about 8 years, so I'm Anna Serafini, and I run the Women with Epilepsy program at UIC, so this is a topic near and dear to my heart. So I was asked to talk about pregnancy and epilepsy, so I'll try to stay in the time limit. There's a lot to cover. A lot was briefly discussed by Irina. So I'm just going to start about what are the numbers. So we know that epilepsy is a very common neurological complication in pregnancy. The prevalence of pregnant women with epilepsy goes from 0.2 to 0.7%. So it's about 3 to 5 births every 10,000 women with epilepsy. So this comes down to about 25,000 children every year. But we also have to remember that a lot of women take anti-seizure meds for other reasons than epilepsy. So bipolar or depression, so this number is probably much higher. But what you see written on the bottom is the most important message that I always try to convey my patient. Your pregnancy is going to be uneventful. Majority of patients with epilepsy do well. The problem is that more education is still needed. And this is why this website that Irina just talked about is so important, as it fills this gap. There is still a lot of lack of knowledge, both among providers and patients, about many issues that are related to women's health in epilepsy. So there are several surveys that have been done throughout the years. This one that is reported here, we know that many patients are still prescribed teratogenic drugs when there are childbearing potential. There's still no documentation about patients being told that there is such a risk, patients being told about the interaction that she just mentioned about contraception and medications. In this survey by Dr. Pack, who's also one of the members of this website that Irina just showed, she showed in the survey that 40% were unaware that medications were teratogenic, and 65% did not know that medications could affect hormonal contraceptives. So those numbers are pretty big. So this is why counseling is really important, and we really need to educate our patient and providers and all different subspecialties as well, and communicate very well with the OBs as well. So what is the first step when we see a patient in the first time in clinic? So before even discussing pregnancy, it's always important to kind of understand the diagnosis. Do you really have epilepsy? Do you really need to take those medications that could potentially be teratogenic? Patients might have psychogenic seizures, they might have syncope, so that we really need to get to the bottom of it and understand the correct diagnosis. Is this a good moment to discuss about stopping anti-seizure meds? You've been seizure-free for so many years. Maybe you could stop the medication before you even think about getting pregnant. And try to do it when you know you have like at least a year in front of you before getting pregnant, and you have all the time to stop the medication and see what happens. Is this a good moment to discuss potential surgery? If you are a patient with a lot of seizures, still non-controlled by medication, do you want to like evaluate this possibility and see if you can remove your seizure before you even get pregnant? And again, also genetic testing. There's a lot of questions about how hereditability is and how will my kids will have epilepsy. So this is another moment that it's important to bring this up at our visits. So what I always tell my patients when we talk about potential pregnancy, I always tell them, we're gonna try to find a balance between your seizures and your anti-seizure medications. So both can have an effect on the baby. So on one way, I don't want you to stop your seizures with too many medications. On the other way, I also don't want to remove your medications, because also too many seizures both can have an effect on the baby, but also on the mother. So today we're going to kind of go over what are the effects of anti-seizure meds and what are the effects of seizures during pregnancy. So the biggest concerns is obviously malformations. Majority of patients are afraid, like what can happen with the medication that I'm taking. So I often discuss those are potential malformations that could happen, and I go over the risk related to each type of malformation and related to each medication. So there can be bigger malformations like spina bifida or heart defects that require major surgery, or like smaller malformations like just cleft lip. So I want to show this graph because this is very important also when we think about what she just mentioned about the number of unintended pregnancy. So here you see the development of the baby and the weeks of pregnancy and when the defects happen. So neuronal tube defects is within the first 6 to 8 weeks. Cardiac defects, same thing. Cleft lip, 6 to 8 weeks. So this is often a moment where a woman doesn't even know she's pregnant. So this is why it's very important to really bring this up very early on and to make sure that the woman is on the best possible medication just in case they get pregnant. Because those are sometimes already happening when they come to us and they know they're pregnant and they're already on medication that could be teratogenic. So this kind of highlights the timeline and why it's important to discuss this early. So we know the medication go from kind of lower risk medication to higher risk medication. Valproate is kind of the no-go zone for women of childbearing age, and not just for malformations, but as Irina said, it produces a big drop in the IQ of 10 points. It can increase the risk of autism. So we usually try to avoid it. So we always go to the lower risk medication. Those are our favorite meds to use. But sometimes they can be challenging situations. We have patients who did not tolerate those. So we had to be kind of creative and find ways to treat our patients and put them at the lowest possible risk for their baby as well. Irina already discussed this. So how do we know what is medication, which medication is safe and what isn't? We know this through the registries. So I always encourage my patient to enroll themselves in the USA Pregnancy Registry, and this is a self-enrollment. But there are many others. So there's the European and there is the UK. And this is just kind of highlights, again, how we go from lowest risk to higher risk. So we have the prevalence of malformation per medication, and each different, the square and the triangle, each is a different registry. You can see how the prevalence of malformation is more or less the same between the different registries. I will say that what differs, for example, European registry with the North American registry is the follow-up after birth. So the North American will follow up for 3 months, the European for like 12 months. So it picks up more cardiac malformations because you see them a little bit later in time. So it's not that in Europe they have more cardiac malformation, it's more that they've been, in this registry, they have been following the patients for longer after birth. And this kind of, you can see this in this graph. This is a graph that me and Dr. Gerard put together for a recent boot chapter. And you can see how the gray, this is the top graph is the North American, the bottom one is the Europe. And you can see how the gray is the cardiac malformation. There's kind of a higher percentage on the Europe one. And again, this is like a similar way of looking at the same data. But again, we have to think about the effect of medication, but also we have to think about seizures, okay? What happens to the seizures? For many years, we didn't really know. So, and a lot of patients were asking, okay, can I get pregnant? Are my seizures gonna get worse? And this was an important question to answer. So finally, this study was done in 2020, and they finally did a study that compared pregnant women with epilepsy with a control group of non-pregnant women with epilepsy. And they followed them for 18 months. So they divided the study in Epoch 1, which is the pregnancy and the peripartum period, and Epoch 2, which is the postpartum. And the results are really good. So the results show that when comparing the pregnant women with the controls, 62 versus 65% of women, so it's basically same percentage, have no change in seizure frequency. So to a woman that asks, can I get pregnant? Are my seizures gonna get worse? This is, finally we have the answer. We can say, actually, you know, whether you get pregnant or you're not, the seizure frequency is gonna stay more or less the same. So there's a small percentage that increase, but in both groups, and a small percentage that decrease, but is also seen in both groups. What is important to see, though, is what happens to the change in anti-seizure medications. So the pregnant women have the biggest increase of medication. So the take-home message is that people do well if during pregnancy you change your medication and you adjust your levels appropriately. So when you do all those changes, this is when the frequency stays stable. When they looked at the pregnant group, about 50% was seizure-free in the 9 months before pregnancy, and the control group also was 47% was seizure-free in the 9 months before. So there was comparable groups. So from this data, it shows that having seizures, the frequency of seizures in the year prior to pregnancy kind of mirrors what will happen during pregnancy. If you're seizure-free before getting pregnant, most likely you'll keep being seizure-free. If your seizures are not well controlled, they're probably still not well controlled. So what does it mean, medication adjustments? We know that the levels of the medication can change during pregnancy, or also patients on their own stop the medications or lower the medication because they're afraid. Actually, this has happened so many times to me. And there's hormonal fluctuations, there's so many changes. So sleep deprivation can also increase the frequency. This is just like a graph to show what all the possible changes in the body of the woman body that can cause a reduction in the levels. So increased volume of distribution, kidney changes, nausea, vomiting at the beginning of the pregnancy that can reduce the absorption of the medication. That's the importance of therapeutic drug monitoring. We really need to follow the medication levels throughout the pregnancy, and we have to do it every month. As Irina was saying, you have to get your levels done, no matter what, okay? So I always tell my patients, come get your levels. And especially with some medications, we know that lamotrigine is the one that drops the most because of the interaction with the estrogen that were just mentioned in the talk about the birth control, because estrogen will decrease the level of lamotrigine. So we have 77% decrease. Oxcarb has a big drop as well. And also levetiracetam, mostly in the first trimester, will also show a big drop in the percentage. Again, it's also very hard to predict at the beginning who will have the drop versus who will not. I have patients whose medications levels stayed perfectly stable throughout the pregnancy, but I have patients that dropped a lot. So what happens if you do have a seizures? This is another big question that comes, that the patients ask me. Isn't the baby going to be okay? Do the seizures have an effect on the baby? So we know that there's different seizure types. We know there's focal seizures and generalized seizures. And unfortunately, there's not a lot of data on focal seizures. Barely any. So we just know based on case reports, we know that there are some case reports of reduction of the fetal heart rate during focal seizures. And then for generalized seizures, this comes from data from eclamptic patients. And we know there is increased risk of hypoxia and also bradycardia in the baby. The biggest risks we know come from falls. Patient is falling and can injure the baby, and the mom can get injured too. Same thing with focal seizures. The risk during a focal seizure, if the patient is not aware, come from indirectly. Like an example, patient is cooking or doing something and they can injure themselves because of that. Again, also, there is some data on the consequences of status epilepticus. There are, on the Europe pregnancy registry, there's 36 cases of status, and of those, 12 are convulsive. And there's, out of those, 1 stillbirth, no miscarriages, and no maternal death. We had 2 cases of focal status epilepticus during pregnancies, and we were able to monitor the EEG and link it to the fetal heart monitor and see what was happening. And we saw that there was normal baseline heart rate during each of the seizures. So even though the patient was in status, but it was electrographical status, this did not affect the baby's heart. Lastly, what is the risk for maternal mortality? And this is also an important concept because it kind of goes back to the initial topic about educating patients and counseling. So the UK pregnancy registry, the UK actually is not the registry, the maternal deaths inquiry, they looked at the peripartum death amongst women with epilepsy. And they saw there were 14 deaths within 42 days postpartum. So 3 of those were complications for seizures and 11 were sudden and unexpected death. So 8 of those 14 women did not get any pre-pregnancy counseling. So they didn't know about like the levels, they didn't know how about having to adjust the medication during pregnancy. So again, why this is very important and why we need to talk about those things with our patients. Last, is kind of a controversial topic at the moment because there is no clear guidelines about it. We know that folic acid is really important for our patients. All our childbearing patients are, even before pregnancy, we put them on a dose of folic acid. As I said before, a lot of pregnancy are unplanned. They get to those 8 weeks before knowing they're pregnant. So if we give this coverage with the folic acid, it really helps. So it has well-known benefits on the spina bifida. There's good results on cognitive outcomes. The NEAT study showed that the folic acid supplementation really helps with the IQ. I will say, though, that we don't have clear guidelines on the correct dose to use. There was for many years, people were saying just use 4 milligrams. There's latest studies that show how the 4 milligrams might be too much. So they're working on defining the guidelines about the correct dose of folic acid they can use during pregnancy. As of now, I'm personally giving 1 milligram pre-pregnancy and 1 plus the prenatals during pregnancy. A lot of people that see patients with epilepsy do more or less the same. So to conclude, before getting pregnant, planning, always. Discuss alteratogenic risk of your medications. Change anti-seizure medications if needed. Try to do it in a safe environment. Try to, if you're taking folic Depakote and you want to stop it, try to do it in a hospital admission and being monitored. Establish your target drug level. That's the level we're going to monitor throughout the pregnancy. We're going to make sure it doesn't drop in folic acid. During pregnancy, check medications, referral to maternal fetal medicine. One of the reasons I was able to develop the Women with Epilepsy Clinic is because I work very closely with the OB and we have a really good relationship. So they send me patient, I send the patient, we constantly discuss all our patients, and then make a postpartum dosing plan. A lot of medication, as I said, they drop, we need to make changes, but then they don't stay that low, they go back up. So we need to make those changes. And postpartum safety. What is the situation at home? Do you have any support from family, your partner? So this is important discussions to have. Thank you.
Thank you so much. That's great. So we're going to move along to our last speaker, Dr. Juan Aparicio, also from Northwestern, and he's going to talk to us about postpartum depression as a comorbidity with women living with epilepsy. I think something that we don't really think about or talk about as much as we should. Thank you.
Thank you so much for that introduction. Hi, my name is Juan Aparicio. I am a reproductive psychiatrist, and so I'm a psychiatrist by practice. I have a fellowship in perinatal psychiatry, and so really focus on working with people that are planning pregnancy, that are pregnant, or are postpartum. And I'm really thankful for this opportunity to be here and talk a little bit about this, but also a little bit of the areas of overlap between what I do day to day and a lot more of kind of the epilepsy world as well. And so, first of all, I don't have any financial disclosure conflicts to disclose, but I do want to just comment that while I will use the term women, I often do so because that's where our data is based and that's where the term that's been used in the data. But not all who give birth are women. I've taken care of plenty of non-binary individuals as well as trans men, and so they need to be acknowledged as well. So let me just start with a brief definition first of postpartum depression. So postpartum depression is not fully recognized in the DSM. The DSM is the manual by which most psychiatry and psychologists really try and define illness. And so we use the same criteria as for major depression disorder. There is 9 criteria, you need to meet 5 of them, and at least 2 of those need to be a depressed mood or anhedonia, meaning not being able to feel pleasure or joy. We do have a modifier that kind of adds on at the end. It's the peripartum modifier. And so that means that this depression started in pregnancy or during the first 4 weeks postpartum. Most of us clinically and in the research space feel like this is not really encompassing the full experience. 4 weeks postpartum is a very early cutoff. And so clinically, we often look at it much further out. So talking a little bit about pregnancy and depression, and this has been touched on some, about 80% of women in the United States will be pregnant at some point in their life. And about half of the pregnancies in this country are unplanned, which has come up some in the past. And so I also want to make a plug for thinking and talking about this early because it really does make a pretty substantial difference. I also want to comment that pregnancy is not protective for depression. And while this may seem kind of an odd concept now, it was not very long ago that in the medical field, we felt that depression protected women from getting illnesses or having symptoms like depression, or that the postpartum would somehow protect women from this as either. And as more data comes out, we find that often it can be the opposite. I do want to shine a little ray of hope that pregnancy, the depression rates are similar in pregnancy as in non-pregnant. We really see kind of that increase happen in the postpartum. That being said, women who stop treatment while pregnant are very likely to have a relapse in their depressive symptoms, up to 65%. So when we look kind of worldwide, we see different numbers, but perinatal depression, really meaning depression during pregnancy or during the postpartum, we see between 15 to 40% of women worldwide. This puts it as the most common complication of pregnancy, above things like hypertension, gestational diabetes, and in many areas, it is associated with one of the leading causes of maternal mortality, which is suicide, or in many other cases, overdose, either intentional or unintentional overdose, and so very tightly connected to things that really make a substantial impact. We see in the postpartum that there's about a 12% prevalence. So about 12% of women in the postpartum will experience postpartum depression. We see that it is higher in low and middle income countries and even higher in marginalized groups. So why do we talk so much about postpartum depression? And while some of this slide here talks a little bit about the things that are unique, I want to make a plug for it just impacts the people who are affecting it. Depression is miserable, and it impacts people in the immediate sense and in the long term. These are some of the ways that are a little bit more unique in the postpartum. It can really disrupt that parental-child bonding, and it is a crucial time for that relationship to build and can lead to substantial consequences going down the line. It can also really get in the way of people being able to return to work in the same capacity, at the same positions, in the way that they had planned. There's also a substantial amount of conflict that can arise between partners in the said in the setting of postpartum in general, but certainly when postpartum depression is present. And we have growing evidence that, particularly when it's untreated, the child's development is substantially impacted. That is cognitive, their ability to meet cognitive milestones down the line, their emotional and social development as well. We see higher rates of the child down the line experiencing anxiety or depression themselves when their parent has postpartum depression, and particularly untreated postpartum depression. So a little bit of kind of where do we overlap? And this really is an area where we need more evidence of how do women with epilepsy experience the postpartum as it relates to postpartum mental health. We have some early data coming out that said that it was a much higher rate, that women with epilepsy had much higher rates of postpartum depression. We actually have really good data from Monid, so thank you, that was looking at kind of this perspective, so looking at the beginning and using standardized clinical evaluations to look. And there was actually no difference in the amount of women who met the criteria for major depressive disorder, which doesn't mean that there isn't a relationship. We actually did see that women with epilepsy had worsened symptoms. Those that did have depression were more likely to have worse symptoms of depression, worse symptoms of anxiety. And there's a pretty strong correlation between frequency of seizures as well as intensity of symptoms. And so there really does appear to be a pretty close relationship there. We just need more data to really continue to explore it. So what are other risk factors for the development of postpartum depression? There's a number of them, and a lot of them are biological, many of them are not. And so breastfeeding problems, and this can be difficulty with latching, difficulty with finding support for breastfeeding, can be a major driver for the development of postpartum depression. Sleep disruption. Having a newborn is in itself really disruptive, particularly if someone is trying to breastfeed or pump or get up to attend to them. And so sleep disruption is a major risk factor. Having depression or anxiety during pregnancy, having a family history of postpartum depression, having a pregnancy or a newborn loss, so having a miscarriage or having an infant die early on is a strong risk factor for the development of postpartum depression. Having a medically compromised child, having your child go to the NICU really puts you at higher risk of things like this. Low social support. Do you have a partner? Do you have a family who's willing to step up and be available both emotionally and practically? These are things that make substantial differences. And then what was your actual birth experience? Was this something like what you wanted, or did things kind of go sideways and really developing kind of a traumatic birth experience? So there's a couple of ways that we kind of try and screen for this, and some of them are a little bit more common, some of them a little bit less. So the patient health questionnaire, or the PHQ-9, is probably the most common kind of mood assessment. It's generally well integrated into most healthcare systems, which is a really big plus, that it's readily available and frequently used. However, part of the questions don't fit the postpartum period very well. They ask about sleep changes. They ask about if you're tired or what your energy level is. Has your appetite changed? Have you had weight changes? These are questions that if you ask someone who just delivered, they'll roll their eyes at you because the answer is generally yes, and it doesn't indicate whether they have depression or they do not. And so not only can it give you either false positives or false negatives, but it can also really get in the way of that building that relationship of trust when it feels like questions are not appropriate. So we have the EPDS, or the Edinburgh Postnatal Depression Scale, which is validated both during pregnancy and the postpartum. It is freely available. It is integrated into some healthcare settings. It actually removed these questions about sleep, fatigue, and appetite and asks questions that are more directly tied to mood. Are you having crying spells or crying episodes? Are you able to experience joy? Are you able to look forward towards the future? As well as include some questions about anxiety, which is certainly something that emerges in the postpartum. And so while both of these are quite helpful and have been validated, I do want to just put it out there that there are different options for trying to do some of this screening. So what happens when you screen and things are positive? And how do you treat? Because we do have treatment for this, and this is something that I really want to focus on, that it's not all gloom and doom, and we have non-medication treatment options. behavioral changes are really big, focusing on sleep, which I suspect is something that comes up in the epilepsy space as well a lot, of being able to protect sleep. For some with means, that may mean having a night nurse or having someone spend the night. For many other people, it means, how do I split the night with my partner? How do I try and bring in family? How am I going to do this? And so there are different options for how to do this. Evaluating the impact of breastfeeding. There is a strong push for breastfeeding, and there are benefits. However, it comes at a cost, and that is often not discussed. And so it is worth discussing what is the benefit here, and what is going to work best for you, for your baby, and your family. And so evaluating the impact that breastfeeding is having. Mindfulness-based interventions, whether that is meditation or gratitude, can be helpful. Physical activity is fantastic. Whether that is light exercise or yoga, both have substantial evidence base for helping in the postpartum. And then things like bright light therapy, often associated with schizoaffective disorder, can be used in other settings to really help as well. Again, something to keep in mind, and something which may be more complicated in epilepsy circumstances, but something that may be considered for those that are not interested in medication. That being said, we do have medications, and actually our treatment of it is not all that dissimilar from treating depression in other periods of times. And so kind of our typical antidepressant options are most of the time still there. Most often Zoloft or sertraline or Prozac or fluoxetine, kind of our go-to first-line treatment for depression, continue to be effective in the postpartum setting, as well as can be used while breastfeeding. And I'll talk a little bit about kind of breastfeeding and how we think about it. Other medications like duloxetine or Cymbalta may be used. Wellbutrin, for those for whom it is safe or appropriate, can be used. And then second-generation antipsychotics, things like olanzapine or Abilify, can be used. And I have a little asterisk by Abilify, and I'll get back to that one as well. We do have some unique options now, which are actually fairly exciting, and oddly have a little bit of overlap in the epilepsy space as well. So in pregnancy, we see changes in hormonal levels, primarily in estrogen and progesterone. And the changes in these have been associated and theorized to be strongly connected to the development of postpartum depression, postpartum anxiety. And so brexanolone, which came out, I think 4 or 6 years ago, along those lines, is an allopregnanolone analog. So it is a metabolite of progesterone. It is a GABA-A positive receptor modulator. And so often what that means is that it helps with mood, it helps with anxiety. When it came out or was announced, it was really exciting. It could help with mood, it could help with thoughts of suicide very quickly, within hours, which is unlike most of what we see within psychiatry. However, the real-life use ended up being quite limited. It required a 72-hour constant infusion, which required a hospitalization and ongoing monitoring. People could not breastfeed. It was very financially expensive, and you needed to be on special registries to be able to provide it, and so it did not have much of an uptake. Fortunately, this past year, an oral version has become available called zuranolone. We don't have a lot of real-life experience with it just yet. It came out right around Christmas last year. However, it's a 14-day treatment for postpartum depression that really does appear to have substantial benefit. Looking through some of this, there is some kind of experimental use that's starting to be used for epilepsy as well. I wish I could speak more on it, but I just don't know. But it is kind of an interesting area of overlap. And then finally, I want to talk a little bit about kind of medication and lactation and some of the ways that I think about it, or we kind of think about it in this field. And I really think about it in three kind of separate but complementary ways. One is using the concept of relative infant dose. This is a concept that is used and proposed by the American Academy of Pediatricians and well supported, and really looks at the amount of medication going through the breast milk divided by the amount being provided to the mom, and kind of provides us a percent. With the general guidelines that if it's less than 2%, it's generally acceptable. If it's between 11 to 25, used with caution. If it's greater than 25, it's generally unacceptable, are the basic guidelines. Fortunately, in psychiatry, the majority of the medications that we use fall comfortably under that 10%. and really can be used. So that is one of the ways that I think about this. The other one is data. What do we know about patients and their children who receive this? And we have growing evidence that, particularly for things like antidepressants, not only does it not seem to increase risk of things like ADHD or autism or cognitive impact, which have been a high concern, there's now some growing evidence that it may be helpful in reducing likelihood of children developing anxiety or depression compared to parents with anxiety and depression who never received treatment. And so I think it really promotes this theory and kind of guiding principle that we have that anything that we can do to help a pregnant individual or a parent is going to help that fetus or that baby. And so we're seeing evidence to provide that. And then finally, it's kind of what is the impact on breastfeeding and lactation? And that goes back to that Abilify asterisk that I had, which while it can be really helpful in managing mood, the way that it interacts with dopamine, it can actually block or make it more difficult for breast milk to be produced or to be let down. And so depending on the patient's goals or kind of where they are in their process, it may not be the best option. So these are some of the kind of the concepts and the ways that we often think about medication and lactation in our space. But yeah, I wanted to once again thank you all for the opportunity to speak.
Much thank you to all of our panelists, I think, for these very insightful talks. And now it's the questions and answers portion of this evening before we go next door. Does anybody have any questions? I just want to open it up to the audience first. We have mics, so I can run around if anyone has some questions. Yes.
Hi, I'm Takia Hurd. I'm one of the pediatric epileptologists at North Shore. And so wanted to ask a quick question about the controversy about the folic acid. I know that you said you've gone down to from 4 to 1. What is the cautions with 4 and why has it turned into a controversy?
There was a study that came out of Norway, I believe, Northern Europe last year, a few years ago probably now, and they showed how higher doses of folic acid were associated with increased risk of pediatric cancer. So because of that, people are trying to look into the data a little bit more. I will also say that 4 milligram was kind of picked not because there's any evidence behind that dose that it really helps. So even the 4 milligram, nobody knew why 4 was picked. So now the people are like Alison Pack and other people that are involved in the guidelines for the American Academy of Neurology is trying to figure out, okay, what is the correct dose? We went like, there was a moment that people were like, it doesn't matter how much, just give folic acid. But this is a good moment to think, okay, what is a good dose to give?
Anybody else? Yes.
Has there been any data or studies showing any increase in SUDEP for either the infant or the mother or throughout that entire process, even postpartum as well?
That data that I showed from the UK maternal deaths, because they have a very good set of data about those things, and so those are the numbers that I had. It wasn't a high numbers of SUDEP, and it was on maternal deaths postpartum. I'm not aware of babies. Yeah.
Anybody else? Oh, sorry.
With respect to the hormonal IUD for patients who are refractory, has it shown to have a positive, neutral, or a negative effect on seizure control?
The IUD, as far as I'm aware, and anyone else up here, feel free to correct me, there's really no systemic effect of the progestin, so really it shouldn't have any effect.
What resources are available for patients who are currently taking medication like lacosamide, for which there's not a lot of data on the effects of pregnancy, if they're considering pregnancy?
So probably you'll find a lot of data on the website. And yes, I agree. Unfortunately, lacosamide does not have a lot of information. So we always want to pick the medication. When you look at it as like, you have the risk of malformations, and then you have the number of pregnancies on that medication. So you want to pick the medication that has the lowest risk, but also the biggest amount of information. And which is the reason why we always pick the same medications, because those are the ones that have been studied the most. So there's really very limited data in the newer medication, but it doesn't mean that they're not good. It's just that we don't know yet, which is why I'm always encouraging the patients, just enroll and bring your data into the registry, and so this information can come out. Because, for example, zonisamide, that for many years we didn't know, current data shows that it's actually good. So it's a safe medication to use from the newest data from the registries. So the more we collect, the bigger the number of the registries, and the more we know and more comfortable we feel about prescribing medication. And this is also why the classes of the medications have been dropped. Like, we used to classify the meds in like class A, B, C, regarding the risks, but you couldn't compare the same medication that had, I don't know, 50 pregnancy and had a risk of 5% versus a medication that had 2,000 pregnancy and the risk of 5%. So you really need to focus also on the number of pregnancies.
Just to throw it out there, there probably isn't data. Is there any data for cenobamate? Because I find myself, even though it's a new drug, it's a good drug. No, is there any data?
I haven't used it because I don't know a lot, so I'm hoping to collect more data. We'll see this AES this year, what the people bring, yeah.
The other, yes.
I'm not sure if there will be an answer to this or not, but just questioning why there is such little research that has been done on focal seizures and focal epilepsy, and just questioning around that, and will there be research in the future?
Yeah, I think it's because you really need to, the data that we want is kind of correlating the seizure with the baby. So it's really hard to get that moment and get the recording what happens during a seizure exactly with the baby. That's why it's just sporadic case reports here and there. But the more, sometimes people don't collect case reports as much as in the past, but I think that those still have important value, especially those things. The more we report what we see during a seizure and what happens to the baby, the more information we have, yes.
Have we noticed any increase of more effectiveness in the rescue medications versus like palliative care devices when responding to someone having a seizure during pregnancy? I might have missed that if that was earlier on.
Sorry, I'm not sure if I understood the question. The rescue medication versus?
Versus like the palliative devices, like the VNS, the RNS, and some of the other devices when someone's having a seizure. Has there been a change?
I'm not sure this was studied during pregnancy, to tell you the truth. So I'm not sure, in particular to pregnancy or, yeah.
So I have a question, and I'm throwing it out to all of you here. More and more are women, their seizures are being better controlled and they're, living life. And I have a lot of patients that undergo IVF. And so how do you handle your patients or treat your patients when they're undergoing IVF with all the different hormonal changes that they're going through?
I don't have a lot of patients with IVF. I know Dr. Gerard is actually head of the committee. We're part of a consortium from AES about women issues with epilepsy. And so there is a committee that is kind of looking more into this, and they're trying to come up with also more guidelines on what to do with IVF. I do what I do in general, like look at the hormones, look at the levels, and monitor things. It's not that I don't encourage it. Or I had a patient who did IVF, and something strange happened. I asked around if other physicians said the same thing. They needed more like hormonal dosing than normal because of my medications. So this is something we've observed. Yeah.
Yeah, I've observed that as
Yeah.
well. I think also I'm maybe a little bit of a nervous Nelly, so I ask for their schedule of the hormone treatments, and then
Yes.
my time lab draws maybe like a day or 2 days after.
Yeah, I will say, yeah, the timing of when you draw labs is extremely important. So I always try to make the patients come to clinic at the same time so I can compare the same timing of the drugs levels. And this is particularly important for hormones, yeah.
Oh, sorry.
Something that many people tend to forget is that in IVF, many times people use birth control to control ovulation. So if you have somebody on lamotrigine, we're back to the when do you go toxic? When does it drop? So you have to think about more things that might be changing.
Their mood sometimes is a big problem during these cycles as well. It's tough. It's tough. So if there were
I just wanted to make one comment about mental health because I think it's very important, and because health equity is also part of the topic. I feel that there's still, and I see that with our patient population, that we have a lot of underserved patients. Access to mental health is still a huge, huge struggle, and with the majority of my patients. So the treatment available, there are things that we can do for them, but the access for a lot of my patients is still not there. And I think as healthcare providers, we need to probably fight to make it more equitable. Yeah.
question was posted before this evening, asking about the effects on women as they get older and when seizures are not controlled about medicine. So what sorts of changes have you seen in your practice with women going through menopause?
So, sorry, changes in seizure frequency? Oh. It depends if, everybody is different. We've had patients who, if the patient has catamenial epilepsy, you might see some certain changes with reductions. Depends of the patients. I had very few patients that had worsening of seizures with menopause, so that you have to take into account. Sometimes you see patients and all of a sudden the seizures get worse, and you're like, okay, wait, this is why. And you also have to think about menopause. What if they're starting to get hormonal treatment for menopause? So this is something else to think about.
One more round of applause, please, for our amazing panelists and our moderator. Thank you, thank you, thank you. I think it goes without saying that this is such a complex, complicated, important topic that's got so many nuances. There are so many entry points onto the roadmap of epilepsy, and so I think that today was a really good example of all of the different conversation pieces. So thank you again. We would love your feedback, and the next event that we are hosting is our annual education conference, so we would love to see you there. But for now, we'd like to see you there next door, so let's go get some snacks and drinks. Thank you.